Here are my disclosures. So in terms of objectives, today we want to talk about some important adjuncts to making sure that spine surgery is safe and efficient. We can talk about perioperative care, and then we'll talk about newer things that we're doing in terms of spine segmentation, which really allows us to do patient-specific plans. So we have to understand that surgery is traumatic for all those that are involved. It's traumatic for the patients, it's traumatic for their loved ones, it's traumatic even for us as surgeons and as medical care providers. And we really need to, decrease our surgical footprint to allow these patients to return to the lives what they want. Recently, I was invited to give a talk on ERAS, and I think one of the big problems with ERAS is that this word after. We really want to talk about enhanced recovery with surgery, and it's a real, continuum of care from perioperative care to intraoperative care to acute postoperative care and chronic postoperative care. If we take care of all four of these phases, we really can ensure that these patients will do well. So in terms of preoperative care, my chief, Dr. Chris Shaffrey, has a whole talk on risk stratification in the elderly for deformity patients and when to say no. And we've really put this really important for us for this pre-op optimization. So we published a paper on this, and we look at 8 main, what we call modifiable factors: blood sugar, blood pressure, smoking, renal function, nutrition, BMI, psychosocial, and bone density. These are 8 reversible things that if you optimize them, you can help yourself ensure better outcomes for your patients. We actually have embedded this into our electronic medical chart. So once we sign a patient up for surgery, the nurse comes into the room and asks these questions. And any of them that say yes, gives us a red flag, and we see, hey, can we modify this before we sign this patient up for surgery? We also have something called an indications conference. So this is a weekly multidisciplinary conference where everyone presents their cases. And we really want to make sure that we do the right surgery for the right patient at the right time. And you can see here our attendance is about 14 or 15, attendees per week. So it's a good attendance. We try to get a group consensus on the surgical plan, the optimization, whether conservative therapies need to be done, or some alternative strategies. We've done this, now for about 6 months, or actually to a year now. We have about 4 to 5 patients per week. And we can see that, only 45% of the time does the first surgeon's plan is what we can, is the consensus. We also see that in 25% of the cases, we have additional therapies that are recommended. So this, makes sure that we've really optimized these patients and done the right thing for them. And then really importantly, that we looked back and we saw that at least 70% of the time, whatever was the consensus was done by the surgeon. We also are using machine learning. This is the Python to really look at a way to risk stratify. And so we can kind of have a predictive analytics about, the rate of complications. We found that actually the Python actually overestimates our complication rate. It would say that we have a 40% complication rate when we really only had a 5% complication rate. Those 5% of patients that had complications, we went back to look, and we found that actually what was implemented was the consensus plan. We also go back in our M&M conference, and we see that if all the complications were discussed. So this is a way to kind of continually improve our abilities to decide that we're going to do surgery. So we go through this pre-op optimization, we go through the weekly spine indications conference, and we finally decide, that this patient is appropriate for surgery. I think most of the people that are on this meeting today are surgeons, but it's really important to understand that one of the key parts of our team are our anesthesiologists. So I have a great relationship with our anesthesiologist. Every time I think about doing a unique surgery or an awake surgery or something, that's kind of out of the ordinary, I talk to one of these folks and we, come up with a plan to do that. We also, need to realize that surgery is just part of the operative day. We have what we call preemptive analgesia. We have regional anesthesia, we have spinal anesthesia, and we have post-op pain management. And having all 4 of these things together really ensures that we have good outcomes for our patients. if we talk about regional anesthesia, I think for the neurosurgeons that are on the call, this is something that I actually had no idea about. Our orthopedic colleagues actually have a better understanding of this because they do this with their hips and knees and so on. So we recently wrote this paper about regional anesthesia. And really, we've done three main blocks. And these are really important to ensure post-operative analgesia for your patients. There's the TLIP block, which we don't use that often. We have the ESP block, which really helps with posterior rami pain. And now we're using the QL block for my circumferential fusion. So if I'm doing a ALIF or a lateral, this will give you actually both anterior and posterior coverage. So for those colleagues that aren't using regional anesthesia, I would really encourage you to either learn about it and do it yourself, or to, if you have a regional anesthesia team, to really engage them in this. Right now, if you look at planning, we have these spinal pelvic parameters. I think that's reasonable, and I think it's important, but we know that the spine is so much more. We have the bony anatomy, we have the nervous anatomy, we have the vascular anatomy, and we really need to start looking at this in a very detailed manner. So that's what we're doing now. So we're using software to segment out the bones, segment out the nerves, and also segment out the blood vessels. So you can see here we are doing what we call, virtual surgery. So after we've segmented all of these things out, we can say, okay, well, if we drill off the superior articulating facet, this is what we have. We drill off the inferior articulating facet, we can see what we have there. And then we can figure out, what are the best corridors to doing an interbody fusion. We can do this at each level on both sides. And this really gives us a real deep understanding of the anatomy, which is so crucial to ensure that we're doing the safe thing for each patient. This takes us to the idea of what we call a patient-specific TLIF. So, for me, a TLIF can be one of three different operations. Number one is what we call the MIS TLIF, is where you do a hemilaminotomy. You try to move the nervous structures to the side and do your interbody there. If you do that through a tube, it can be quite, a small space. So you have a risk for a CSF leak. We have risk for a nerve root injury. The second method is what we call a transfacet TLIF. So this is going through the facet joint. For the neurosurgeons, this may be a little bit foreign for them, but we'll talk a little bit more about that. And then finally, we have what we call the transcambin or the percutaneous TLIF. So we've been really, over the past year, very concentrating on Cambin's triangle. It really is a three-dimensional structure. So we should probably call it, as my colleague, Dr. Mike Wang from Miami calls it, Cambin's prism. And so we've done a recent literature review where we looking at CT anatomy, how big the Cambin's triangle is. We found that as you go caudally in the spine, we found that the Cambin's triangle increases. And then, as our endoscopic colleagues will tell us, if you do a foraminoplasty and you take off the superior articulating process, you can actually double the size of Cambin's triangle. Now, this is looking at CT-guided anatomy. We also find that, if you have a spondylolisthesis or you have a disc herniation, that will actually decrease the area, which is really important so that you ensure that, you're doing the safest thing. Now, we kind of ignored the exiting nerve, which is really important, especially with the DRG and so on. And so now we're actually using our cranial software to map out the nerves before we do surgery. And then when we did that, we found that, certain things that were really interesting. Number one is we can see preoperatively if there's a conjoined nerve root. So on this side here, we can know preoperatively. So of course, we're not going to go on the side because, Cambin's triangle is going to be too small on that side. We also found that if you take the nerve into consideration, the Cambin's triangle will actually decrease, especially more proximally. And this is something that we all know as spine surgeons, but this is now giving us patient-specific data. So right now we're manually segmenting out the nerve, but we're going to actually use this kind of as a ground truth to do automatic segmentation. We're also starting to use different types of augmented reality to do this as well. So here's a case. This is a 76-year-old lady with a grade 2 spondy at L4-5 and L5-S1. This is how kind of the day goes. She gets an ESP block. She gets a spinal anesthesia. She listens to her music while we're doing surgery. We put in the screws. We then, it's my standard operating procedure to get a CT scan after I put my screws in to make sure everything looks good. We merge that CT scan with a preoperative MRI where we've segmented out the nerves and so on. And then we can do this percutaneous method entering into the disc. And here you can see that where we're missing the exiting nerve root. And we're able to do this surgery completely percutaneous. This is a percutaneous surgery, so minimal blood loss. And we can get a 2-level T-lift to go home the same day. And then we don't ignore the spinal pelvic parameters. We make sure that we've done well by her spinal pelvic parameters as well. Now, just because you have a hammer doesn't mean everything is a nail. So in this situation, we found that the Camden's triangle is only going to be 6 millimeters. So in this situation, doing a purely transcambden approach is not going to be safe for this patient. So this takes us then to this transfacet corridor. And that's if you keep the facet joint kind of in the middle of your operating field, you can get into the disc and have a wider space. So this is kind of how we've done that. We've compared the transfacet corridor to the Camden's triangle. This is a paper that just got published or just got accepted, where we've looked at the different areas. So the transfacet corridor versus the Camden's triangle versus, quote unquote, the safe triangle. So here's a case. This is a 36-year-old gentleman with a grade 2 spondy. You can see here he's not a good candidate for an A-lift or an O-lift, and not really a good candidate for a lateral. So what we do is we go through the segmentation. We do this transfacet pathway into the disc. We put in the screws. We merge the CT scan to the MRI, and then we bring in the microscope, and we're drilling right here, keeping the facet joint in the middle. We're avoiding the exiting nerve root. We're avoiding the traversing nerve root. And actually, as I'm operating, we have this heads-up display. So this is using augmented reality to make sure that we're safe throughout the procedure. We have newer implants that we're putting in, which are 3-dimensional cages that widen both in the AP and the lateral. So this looks like an A-lift, but this is all done posteriorly. And we can get this patient to go home, again, within 24 hours. So as we said, we're going to do using this, manual segmentation to do then automatic segmentation. I think my time is coming up to close here. So I think the future of spine surgery, we just concentrated on preoperative care in this talk, but I think that we need to really look at, who should get spine surgery and which surgery. I think the combination of regional anesthesia and awake spine surgery is really important. I think this nerve segmentation is really important, and using the right approach for each patient at each level is really important. And with that, I'll conclude. Thank you so much.
Great presentation, and really personalized approach to every patient. That is definitely something very new and very interesting. And how long have you started doing that, and how many patients so far you have under the belt with this new approach?
So we've been doing it for about a year. We actually came up with the idea in 2017, but it took me about 4 years to really find, a good way to do it. For all the young surgeons out there, don't get discouraged. If you have a good idea, keep fighting the good fight, and you'll be able to do it. I think we're probably up to 50 patients now, and this is we do for every patient that comes into my clinic.
That's excellent, and I would be very, very interested to see your results when you have. I'm sure you will have a big number of patients very soon, and I will definitely follow that myself, and I will try probably to apply. I also do a lot of T-lifts in my practice, and I'll definitely try to apply some of your principles maybe in my practice as well. It was very interesting. Okay, I think probably we'll leave some discussion time at the end. So maybe we proceed now with the second speaker, which was the first speaker initially, Federico from Italy.
Good morning. Do you hear me?
Yes. Good morning. Yes. Thank you. Thank you for joining, Federico. Federico, for those that don't know him, he is the founder of Upsurgeon, and this is a very interesting project. We will hear what is the latest that they're doing now, probably.
Thank you very much. Yes, I am very happy for this invitation. Sorry for my voice. I have a little problem to my inside field. So I will share my screen. We share my presentation. So do you see my screen? Okay. Can you tell me if you see my screen, please?
Yes, please. Everything is okay. Please carry on.
Okay, fantastic. So I am a neurosurgeon. My specialization is skull base. As you gently said, I am also founder of Upsurgeon. Upsurgeon is a reality founded by a group of neurosurgeons in 2017. And I will share with you what we have done so far and the history behind this project and how we did our steps into the spine side. We started from the from the cranial, because I am a cranial surgeon mostly. So we started in 2017, and the idea was let's say that there is this traditional idea that training in our discipline can be done only on cadavers or only on animal tissue, but this is exactly what we didn't believe, and probably, as you other speakers in this conversation are demonstrating, this is not the only way. There are other ways, and first of all, there is a new mindset that is arising day and day. So, in my experience with the Young Neurosurgeons Forum of the WFNS, I am a part of the committee of the Young Neurosurgeons, working with Ignatius Aizin and all the team, and we did many things in the field of education in the last year. So the idea behind what I am talking about is this. I mean, in any discipline, we train our abilities doing repetition of an exercise. So in music, sport, everything, we do repetitions. In our disciplines, this is a bit provocative, but this is the reality. In our discipline, we become skilled only practicing directly on patients. So if you take them residents, for example, of the same school, at the end of the cycle, they will be completely different one from another, because they have different chances, different days, different masters. So there's no a standard way. So any one of us is exposed in a different way to different experiences. So these make education randomic. So if we want to give anyone the opportunity to do the same thing that other skilled people can do, we need to give anyone the opportunity to try to do errors in a safe way. So this is basically, this is not my idea. This is the idea behind simulation in general. So this is very important. It's a culture. So this is of my discovery. I mean, the way clear that we need the timing in the exposure. So if we access a specific surgery randomly, there's no way to train this, to learn these things, unless we do not spend 15 years randomly around the operating room until we find the day, find the patient, find the opportunity to practice. We take this, we give this for granted. Any one of us did this. This is how it works. We are wondering if there is another way. not to replace this, but to boost this, to reduce the time, to reduce the risk for patients, to improve the outcomes of patients. So what we see today is that world is changing in any discipline. So from sport to military to aviation, in any discipline, technology is entering, first of all, to give us a mental training, preparation, and but also, and this also to evaluate the quality of an operator. Meaning that today we don't have a system, of course, to measure the ability, and this is something that we should achieve. So the possibility, like in sport, to classify the way is not to do something bad, but it's very good if we give any surgeon the possibility to understand where I am doing right, where I am wrong, where do I need to continue training. So I have no idea what I am missing. I just jump into the operating room and I start operating. So this is exactly what we are trying to increase. We started collaborating with the WFNS, with the Young Neurosurgeons Forum a few years ago, and the numbers behind the problem of education are, there is a lot of malpractice claims that there's not enough education and not enough neurosurgeons, and in high-income countries there is a problem of quality. So there are pathologies that can be treated in other countries, in low middle income countries, but in other countries there is a problem of quality. So a lot of malpractice claims, and as you know, lower exposed the experience. There is some literature that we also, Franco Servadei, when he was a president of the WFNS. So we studied this problem. And the issue is that traditional training is based on practice on patients and practice on cadavers. And the paradox is that in 2023, we don't have any objective metrics in surgical and clinical performance. And this is what we need to achieve. And this problem affects the life of millions of people. So big markets like healthcare, medical device, insurance company, millions of people related with this issue. So how we started as a research team, how I started moving my first steps in the training and before the training in the technology to boost the training. Of course, I will start talking about cranial, but I will finish my presentation with the spine education. We started on skull base. I'm a skull base surgeon, so we started doing the so-called quantification of the tumors. So, for example, quantification of an approach. I started on skull base tumor, and the studies that we started doing were using 3D models, using segmentation, how to evaluate a specific corridor reach a specific or located in a specific area. Started developments and other developers as a private experiment. We started creating the first tumors, the first segmentation of real tumors, and we started creating real, let's say, simulations of resections. And at some point, we started having the first nice of a tumor before a surgery, or grammetry, having the understanding of the three-dimensionality of a corridor. So we started understanding with these first studies that we needed to train our mind before. And this was the first step, understanding that virtual reality can give you this opportunity. But this is the first step. Then you need the physical. We continue to study on the vascular, quantifying different aneurysm and different approaches, etc. So now I do a jump. This is 2023. After these first experiments, where we are today. Today we are using augmented reality, using simulation to do very sophisticated things, and I will tell you what. So today we created a metaverse, where we have a mental training, entering an OR and understanding how to interact with instruments. But this is the first step. Then we need the manual. We need to go through the real experience, through the real errors on the physical tissue. And in the middle, there is the metaphysical, meaning that we are mixing realities because we need mental, but also psychomotor skill education. So we need to experiment. And sometimes this is difficult because we need to be there somehow. So we use virtual reality to see, and we use physical reality to touch. We need to cover all the senses. So this is the advantage. A series of disciplines around the globe collaborate with spine is the topic of this talk, and of course I will tell you at the end what are the steps in the spine side. We started as two neurosurgeons. Today we are 40 in the team, and is a community of colleagues around the globe, which is more than 100 people around the globe. The core of these activities, the Young Neurosurgeons Forum of the WFNS and its leadership. So it's very nice to see this great number of courses. And thanks to these activities, in 3 years, we did the so-called Global Training Program, which is a program of free courses in low and middle income countries supported by Upsurgeon, where we create education in places where cadaver is not available, for example, or where specific kind of education are very difficult. And in only 3 years, we did 45 courses, in always with the global, with the World Federation of Neurosurgical Societies and the INF. So this is the result. And at some point, obviously, everything is just if we do not validate. So we started also working with several institutions around the globe to demonstrate that the use of simulation can increase abilities. So this is an example on cranial, but I will move now to an example of spine, for example. And this is another example. On the left, you see a leader of the Stanford University training a young surgeon on an anterior procedure. So what you see on the screen is something very lifelike, and on the table you see a lot of technology. And so the situation is very realistic, let's say. So it's also an emotional impact that you need to have. And what they are doing on the right, and this is an example of advanced simulation on spine, is the procedure started from the skin incision, and this is the small box that they have in front of them. And probably you hear the beep. There is also the pulsation of the carotid. So at some point, all the approach step by step is done, and the carotid is you need to use your finger to understand the position. And mobile and for the situation where we need to go to overcome the limits of a cadaver. What is the next step? We are using data collection. We are using data collection to perform, to understand how we move hands, or to understand what happens in the tissue when we touch an organ, for example. And this is what is happening in 2023. We need to collect this kind of data, and we are analyzing tons of data to create the first AI-based co-pilot. So imagine a system with a camera observing you and giving you real-time feedbacks on what you are. This is amazing because you can use the complications and understand that we need to understand what happens emotionally to a surgeon when face a complication, because training is not just hands, it's not just mind, but also when something unexpected happens. And then the frontier is obviously arriving to the patient specific, where we need to be able the day before surgery, we need to be able to go through the same surgery. So using these things, we created a methodology starting from cranial, and we created the first archive of digital models, and then we created the first archive of physical tissue. So we created an archive where there is the spine, there is the dura, there is the bone, there is the vessels and everything. And then combining all these elements, we are reproducing every day more we do more so in new countries with this kind of activity. Now we enter the topic of the spine, and I give you some example of I mean the way we are using simulation to go through spine procedures. So this is an experience that we are doing on posterior, for example, where we go through the steps of the simulation, in this case a laminotomy. And the fantastic thing behind this is that, for example, these videos comes from a course where 15 residents first year, so PGY1, started with no experience in the morning and finished the day with the let's say a small curriculum of 8 spine procedures in the same day. So we see during these kind of courses people that never use the drill doing a perfect decompression at the end of the day. So this is what repetition gives to this guy and to these guys. Give the opportunity to do many errors in a very sophisticated and fast way. And this is another example on spine. So imagine the possibility to do procedures, and I will show you step by step at the compression. And so is where, for example, there's just one topic, lumbar spine, and the trainees do multiple times the same procedure on lumbar, and at the end of the day, they need to go through the steps. So the direction of the flavum, they need to do this multiple times, and then they go to next steps during the operating room, and then you need to wait another day for another experience similarly to do again the exercise. So again, exposure of an herniation, for example, and you need to do the same exercise multiple times during the day. And in this way, and see, if you imagine there are people that do this kind of courses multiple times a day at the which is like a boost in specific steps. So whatever you need the patient. So obviously this doesn't replace anything, but in this moment, this person is doing errors, for example, and you can do errors before. And when you arrive to cadavers, you need to be, let's say, I mean, you already did the basic errors and you are ready for the, let's say, the complex errors, but anyhow, you need to do errors. So what we are trying to do is to create the opportunity to do as many errors as possible in the fastest way possible. So this is just an example on how we are using simulation. Of course, there are multiple ways, and I conclude with these multiple ways to use, of course, to use simulation. So this is an example of one of our courses. So you see stations where people operate the entire day, sometimes are multiple days, and we use master coming from all over the world to do very cadaver-free courses. So the goal is to do cadaver-free, not because we don't like cadavers, we need cadavers, but cadaver is the second step after this. So it is important to arrive to cadavers after we understood the majority of things. Now the goal is to sensorize the simulators, and this is actually what we're doing, using virtual reality and AI to understand how to, let's say, identify parameters to grow. So in this case, if you start doing things and you start collecting data, we will discover % of these data. So just on these data will give you a better understanding how your learning curve is proceeding. So of course we have virtual reality because virtual reality gives you to think. So you need to learn to think first. And also in these environments, you can do errors again. So also in the virtual environment, you can do errors, and we need to measure these errors. So in other words, we need to be able to understand our learning curve. We need to understand where we need to push. We need to understand where we need to go with our training. And if we achieve the incredible goal to reach this kind of understanding, this for the next generation of surgeons, incredible for them to master in understanding also that the revolution will be led at some point by patients, because probably it's scary for surgeons And for our generations, it's scary to think that technology will give us the opportunity to be, let's say, visible, to identify our errors, to identify our improvements. But patience at some point will ask for this, and we need to be prepared to this. So thank you very much. And sorry again for my voice.
It was a great and very interesting presentation. Many thanks for preparing that for us today and for your time. And definitely the idea of cadaver-free courses is very valuable, and it is very good that you're working in that direction. And we all seen that your models are very realistic. They bleed, and everything looks like a normal. And I quite like the idea of juniors doing one and the same procedure many times in the same day, because that will give you a boost of your understanding and everything in a very short period of time. So we will leave the questions for the end of the webinar. We have a third presenter. He'll actually tell you now what is a few words of the trade with cadavers, and that will further emphasize how important is what you're doing. So let's see the third presenter, and then we will have a good discussion, I believe. So the third presenter is Manuel Encarcion. He is at the minute in Moscow, and he works and develops there in Moscow, originally from Dominican Republic. He does a lot of work on 3D printing, and he will present now what is he able to do with 3D printing. So if we can, Manuel, are you on?
Yeah, I am here. Thank you so much, Dr. PF.
So you can share your screen now, and we can continue.
Yeah, yes, fantastic. I will do it now. Sorry, because I have some technical issue with my frontal camera. So I'm gonna start to share my screen right now with all of you.
Okay.
Yep. Do you see it?
Yes. Please just start your presentation.
Yes, fantastic.
Yes.
Thank you so much, Dr. PF, Professor Sharif, and all the team in charge of these projects. Thank you for the kind invitation. So today we're going to talk about the neurosurgical self-made, low-cost, three-dimensional printed model for training in neurosurgery, okay, in spine surgery. So first is we need to know why these kind of models are important, why they're useful for us. Because we already know the cadaver is the, of course, after the patient is the most important part of the trainees. Because, you know, we cannot say we are training in the patient. It's not ethical, okay? Sorry about my voice. It's Moscow weather affecting me. So, as you can see, in a lot of countries all over the world, we have this kind of companies they call body brokers. It's totally legal. They sell a part of human body for trainees, for educational purpose, for science too. United States, Canada, they are leading this kind of companies. But of course, the cadaver for trainings, they are not available for everybody all over the world for different reasons. Here, I show briefly our modest experience in this kind of 3D models tools for science projects from trainees and so on. Okay, so what is the goal? What is the target of our speech? Is try to show how all kinds of neurosurgical departments all over the world can produce themselves 3D printing models. Because something we figured out is 3D printing models is not sending a rocket to the moon. Of course not. It's much more simple. I always say, if I can do it, you too. Okay, so 3D printing, it's expensive or not? I put here true or false, because a lot of people think 3D printing is so expensive, we cannot affordable. You know, we hear that before because we don't know, and the one who don't know is the one who don't see. This is the two kind of 3D printing machine. Simple one, I don't have any kind of conflict of interest. I use them, both of them. I have it even here in the balcony of my place. And you can see this one is the resin one, and this one is a filament one. This is a basic concept we need to understand while we are talking about 3D printing. Okay, this is not industrial 3D printing. This is like a desk 3D printing, and we need to understand this. One is photopolymer, this one, the resin one, dentistry resin, and this one is filamented. It can be plastic, can be nylon, okay? Okay, so here are our goals. Yeah, this is the part we already know. We can use the 3D printing model for show how it's gonna be the procedure, how to show to the patient. This is the technique we're gonna use. This is we're gonna use this. It's called a screw, etc. And of course, the classic one. This is one of the classic way we use the 3D printing spinal model to train in the pedicle, in the screw pedicle position. Yeah, so the neurosurgical training, as we know, we can divide in different parts. A part in the operation room, but again, we cannot say it's a part of a training because ethically it's not right. So we have the cadaver lab and we have the simulators. The cadaver lab, we have a fresh cadaver. They're fantastic, but they are not available in not everywhere. And the fixed cadaver. The tissue composition is different, okay? So the problem with the cadaver for training is we have the lack of donor. Something, unfortunately, the COVID-19 teach us is the cadavers don't gonna be forever because if we have war, medical issue, again, we're gonna have a lack of cadaver. Again, the lack of reproductivity, because in the cadavers, we cannot simulate the herniation, we cannot simulate a spinal tumor, no. Also, we need, of course, the legal issue. This is all over the world. And of course, I put in the end, but not because it's less important, the cost. Because sometimes we see like cadaver trainings, wow, $2,000, $3,000, it's so expensive. But the problem is cadavers, buy the specimen for training, it's expensive. And all the equipment necessary to carry on them, it's too. So here the advantage and disadvantage, okay, in the operation room. Of course, as I said before, bioethical issue, legal issues, okay, difficult to practice complex cases because we cannot, it's like an oxymoron. We cannot say practicing or training and patient. Put together, it's like, we have a conflict there, okay? But the advantage is we have a real scenario. We have all kind of pathologies, all kind of complications, okay? Usual technology, and of course, we are under our master's professor's supervision. The neurosurgical training in the cadavers are, again, advantage and disadvantage. I put it here for you, okay? Again, with the training models, advantage and disadvantage, okay? We need a similar anatomy, okay? It's a big advantage. We don't have infectious risk. They're possible to practice any kind of pathology we can reproduce on them. Of course, low cost. We can use them in any place. We even can take them in a plane for practicing in another country. Of course, disadvantage, the unreal scenario, the unreal consistency, okay? And universal acceptance, because in some places they don't accept, they don't like this kind of technology as a boost for improve the training skills in the neurosurgical. So this is like the characteristic of the real training model you need to have. You can see it here. This is, I can say, this is one of our first training model we developed. I think this is me. You can see here, that was in 2006. Okay, so the method, how we can start to do this, because yes, the 3D printing, okay. The first is we need to take a healthy volunteer. In this case, I use myself. After we take the CT scan of the volunteer, we transform in DCOM. After we have this DCOM file, in a lot of free program, we can transfer this STL file, okay, and it's all available for 3D printing in a lot of 3D printing machine. First step, CT scan. After we have the the vertebra or the spine segment, we go through DCOM file to STL. Okay, we have a lot of very easy tools for using in internet, free of use. Okay, so here we're using this is illustration of my good friend Carlos Ovalles. You can see here this was in the Federal Center of Neurosurgery in Tumen. This was in vertebroplasty model. As you can see, this is a simple 3D printing model, very cheap. Later I can tell you how much it can cost, produce a full set of this. So you can see here, you can see this model is of resin one. Why resin? Because the resin feels better in the tag and react better to the drill. When you are drilling these resin models, it's react like a real bomb. A difference of the plastic one is can melt because the friction and the get hot, for the friction get hot and then get melt. So it's no good. In this case, we can say it's not the best way to use these plastic models. Okay, so better we move always to resin photopolymer one. So you can see here for makeup laminoplasty is very easy, very affordable, and very cheap. I can use the word affordable, but no, I can say cheap because the cost for make a full cervical models, let's say at least five, 6 cervical models can be $30. Only $30. You can already teach a whole group of young neurosurgeons to perform laminoplasty. You can see here more illustration. And so after that, we make a small survey, and then that was the answer they have for all of us. Sorry. All 89% of them they really like it. They react very positively to this kind of model. They say like it's extremely useful. More than 31% of them say it's very useful as an accessory tool for trainees, exactly in the first years of the residency program. They strongly agree because they say these 3D models can enhance their neurosurgical skills in future for all kind of neurosurgery, because we don't need to use the totally of the full body for perform this laminoplasty. So they prefer, 23% of them prefer to use this kind of very affordable model for very precise kind of technique. So another kind of models is tumors one. Again, as I say, we perform the DCOM file, STL file, and then we can use any kind of 3D program for make the part the tumor or any kind of pathology we want to include on them. In this case, you can use Mesh Mixer. It's a free tool, free program. So here you can see the spinal cord is made from an endotracheal tube, and you can see a silicone tube represent the nerve. A silicone layer is used for the dura mater. And again, we already know because it's very good for the drilling and the process of bone removing the photopolymer cervical segment. You can see here. So as you can see, the residents can perform step by step to get used to this kind of systematic steps in the tumor removal. Okay, is have later we want to improve with this CSF circulation. You can see here dura. You can see this is the tumor. So you can see here, after the tumor removal, the participants can practice the watertight closing, the dura mater. Yeah, yeah. So in this kind of model, we have a very positive feedback. Of course, this is experimental models. The idea is make them very affordable. Of course, we can use a silicone, the same silicone I already used for make the brain models. We can use from the spinal cord and use another kind of different silicone for represent the tumor. But the key idea is to make them affordable, more affordable. They less than, let's say, $50 to produce 5 or 6 of them. So also, of course, in spinal training, we can perform our self instruments, because we can perform this kind of retractors. These are retractors we already make with 3D printing. Because if the for the trainees, if we want to, if the department don't have the proper equipment for different reasons, we believe all the department can reproduce themselves, can create themselves the instrument according to the necessity. This very simple retractor, it can be a guide for the pedicular screw. Of course, remember, this is the idea is can be for the low-income countries, because you can tell me, yeah, we can use the navigation one. Yeah, but remember, which one is our target? You can see here in action. This is the patent. Also, of course, we can create ourselves the interbody cage, because the idea is also the department can create their own equipment, even the cage. You can see here, this is the result of a patient after the use of our cage, no migration. You see, this is the article about it. So in conclusion, as we see, 3D printing came to stay. Yeah, it's a reality. It's very simple to use, and we believe all departments of neurosurgery all over the world can have a huge benefit of this kind of technology, because it's very affordable. And now we have experience, and with our experience, we believe we can reproduce this model very, very easily. And in the end, of course, remember this: one day when we are not here, we will be what we have done, and in the way we change other people's life. Thank you so much.
Thank you, Manuel. Manuel really showed us how we can do and utilize with minor effort, with not so much money, teaching at home. So I don't know if we can all do it at home, but definitely Manuel has good experience with that, and he has shown us that this is possible. So I think it was a good 3 presentations so far, and I'm happy to hand over now to Mirza Poskic, who will manage the session of questions. Manuel, please unshare your screen.
Oh, yeah, sorry. I unshare my screen already.
Okay.
Yeah, I did.
So Mirza, what are your comments on what we have seen? And I encourage also the other members of the panel to participate. Thank you.
Thank you, Nikolai. And I want to thank all three speakers for really amazing presentations. We've heard and learned so much today. And I invite everyone who has participated in the webinar to make any questions in our chat. Until these questions occur, I have several questions of my own. And I would start with Mohammed. Mohammed, first, thank you very much for the great presentation. You've built a real spine powerhouse at your department. And I think the term awake spine surgery is now synonymous with your, and in that light, I would like to ask you, in your opinion, what would be the biggest challenge in introducing an awake spine surgery in one department? If, for example, any of us would like to start it, we would, of course, come to you and see how it's done. But what do you think? What is the one thing you should not even start to think about it if you don't have it, and if you want to do awake spine surgery?
Well, Mirza, thank you so much for your nice comments. I think that when you talk about awake spine surgery, I think it's really important, as we talked about in my talk, is to have a great relationship with the anesthesiologist. And part of building that great relationship is that you have to prove to them as a surgeon that you can do your surgeries in a safe and reproducible manner, right? So when they know that, Dr. Abdulbar puts on a one-level TLIF, it's going to take 2 hours plus or minus 10 minutes. It's not going to be 6 hours. It's not going to be 5 hours. It's going to be exactly 2 hours plus or minus 10 minutes. You have to really use minimally invasive techniques because they're not going to want to do awake spine surgery on patients that you lose a lot of blood. So if you look at our 1 or 2 level TLIFs, we lose less than 50 cc blood loss, and that's by using endoscopic techniques and so on. If you can do those two things reproducibly and safely, then you'll be able to, have a good team with your anesthesiologist. So that's very important.
Are the patients who you choose for awake spine surgery more young, healthy individuals, or are they more people which anesthesia deems not to be suitable for general anesthesia? What are your criteria, more or less?
Yeah, great question. So we actually have 2 publications that came out that shows that you can use awake spine surgery on both extremes. So you can use it on people, as you say, that are very high risk. So, we had a recent patient, 92 years old, very old age, very frail and so on. Those patients do very well if the patient and the anesthesiologist and you come together and decide that they're a good candidate. But then if you compare apples to apples, if you compare a one-level fusion that is maybe not so old, and if you compare them in terms of BMI and age and so on, we showed that those people that have awake spine surgery do much better in terms of their overall opioid use and length of stay. So it actually helps you increase your surgical indications, but even for the same patient, really allows you to do safer surgery.
Did you ever have a patient who you planned to do awake and then for some reason needed to do general anesthesia? Do you have a generally backup plan for such cases?
We do, and it's actually been very rare that we actually had to abort. One of the good things about doing endoscopic surgery is that if you're in the middle of the surgery, we had one case we were going to do a 2-level endoscopic decompression. Unfortunately, the patient developed this coughing sensation, started coughing a lot and so on, and we had to abort after we did the 1 level. Luckily, there's no incision, so you can just put 1 stitch in and turn over. So again, you can't do this if you're doing open surgery. You really have to do a minimally invasive surgery.
Okay. I have one technical questions. You've shown 2 cases where you put first the percutaneous screws, and after that, so control CT, and then TLIF. Do you remove the towers of these screws? Do you lock them and then do the TLIF on one side, on both sides? because they would, in my imagination, they would be going in a way of your surgical corridor for the TLIF.
Yeah, great question. We actually found that usually these towers are very flexible and you can move them out of your way. So normally we don't have to remove them. And I put them in there and I get the CT scan just to make sure that, you know, everything is good in a good position. And then we do this merge. And the merge is actually very robust and it allows you then to do this safe trajectory.
Okay. What was the highest number of levels you did in a patient with spine surgery? Is that more like a 2-3 level story, or would you be able to do a longer construct with it?
We've used it for mostly 1 to 3 levels. You know, in general, if I'm doing more than 3 levels of intrabody, then I'm doing laterals or anterior and so on. So those are for more of my deformity. So this is more for the degen population.
Okay. Your algorithm has overestimated the number of complications, the PTL. Why do you think that was the case?
Yeah, great question. I don't actually know the answer to that. We'll have to look more carefully to look at that.
Okay. Okay. Well, thank you very much, Mohammed. Those were my questions. Are there any questions? So Federico, please. Federico has a question for you too.
Yeah. Yes. Mohammed, thank you. Fantastic presentation. I have a question for you. Did you notice any difference in the postoperative pain management between a traditional way and an awake spine surgery?
Yeah, so we have a recent paper that was published, I think, in World Neurosurgery that came out 2 months ago. So this was a matched cohort study to look at 1 or 2 level fusions that were either done general anesthesia or spinal anesthesia. And we found that, and this is, you know, it surprised me a lot when I looked at the data, 50% of the patients that were done under spinal used 0 opioids after surgery. And the reason that is that when you're under general anesthesia, it's a more on and off. So you're asleep, you wake up, and you find yourself in a lot of pain. And so the nurses are playing catch up and they give you opioids and so on. With the spinal anesthesia, you're awake and it wears off slowly. And so that gives us more of a chance to give you other analgesics before we do opioids. And so we found that 50% of those patients take 0 opioids and they take 90% less opioids in general after surgery. So it makes a huge difference in terms of the pain management.
Amazing. Thank you.
Are there any more questions for Mohammed from the panel or from the participants? If any of them occur, Mohammed, I will get back to you.
Absolutely.
Thank you. So, Federico, you're next. Thank you very much for the great presentation. And I think your company and the simulators which you produced, they've started a revolution in the neurosurgical training. And we at the WFNS Spine Committee appreciate that involvement a lot because we've conducted several courses in Africa for young African neurosurgeons. And at one of them, we had a workshop with Upsurgeon. And it's really kind of becoming a standard for neurosurgical training all over the world. I live and work in Germany now, but I was raised in Bosnia-Herzegovina, where I finished my training. For low and middle developing countries, I think it provides an opportunity which was not possible, which was science fiction just 5 or 10 years ago. And thank you for that. In your eyes, do your models have any limitations? Do you see any kind of technical advantages or any kind of improvements you would like to perform on them? Because they look really realistic. It makes you wonder that the model can be so realistic. But is there something which you are not very, very happy about? Any kind of region where the model should be better, or any kind of setting, anything in that way?
Thank you for this question. Thank you also for your appreciation. Yes, I think we need to go beyond the limits of 3D printing, meaning that if we want to make a our training impactful, we need to train people in the most difficult steps. And I refer to soft tissue, I refer to intradural anatomy, I don't know, to arachnoid. And that is where we need to go, because a surgery, there are many steps, and being prepared on just one or two is not enough. We need to be prepared to all of them. And my short life is to have to go through, I don't know, tumors inside the spine, or we're trying to go there, but it's very difficult. And today we are very stuck into the current technology. 3D printing cannot help in that, so we are forced to use other techniques, other ways. And I would love to have a 3D printer able to do all the tissue we need and everything. That would be fantastic to have a preoperative reconstruction of a patient. Probably this will be the future, but today we are limited. And what I like with the experiments and the in-house experiments is that they answer to a need, and this is the culture that is changing. So when I see another group or company or even individual trying to push the traditional way at home, doing something, I see the culture changing in this, and I appreciate this very much.
The big word nowadays when it comes to simulations in surgery, in neurosurgery, spine surgery, are the so-called patient-specific models. Do you have any ideas or plans moving your models to really patient-specific models? This is very near to the last subject we had today, to the last talk, to patient-specific 3D printing.
Yes, we have. We just won a grant to invest on a specific research that we just started on patient specific. So we are working on cranial patient specific at the moment. So like our patients. So the idea actually is outside the operating room, and outside. And at some point, the surgeon comes and say, the surgery went well, we will operate you tomorrow. So that was the patient waiting for his surgery. So this is the idea. And the avatar patient is the ability also for an insurance company or an healthcare system to provide for a specific complexity, to provide the case to the surgeons several days before. It's actually what my colleagues like Mohammed, they actually are doing already. We are trying to bring this to a wider level, also pushing the limits of the hard tissue, working on soft tissue, working on adhesion around the tumor, and all these things. So yes, in one word, yes, we are working on patient specific. I think is a great thing we should achieve altogether.
You're a skull-based surgeon generally, or mostly. That is your specialty and your passion. And there are some skull-based school, very influential, like Al-Mefti school or Krish school, who are swearing on cadaver training. Do you see any place for cadaver trainings now and in the future for training on cadavers when you have very realistic models which are actually cheaper than a cadaver course and easier to obtain?
You mentioned a fantastic example. This is a great question. Look, one of the most disruptive pathology in neurosurgery, when I say disruptive, I mean that transform completely the normal anatomy, is a giant skull-based tumor, for example. So all the anatomy that you expect on a cadaver is completely, you don't find this. So the people that knows this most, our key opinion leaders coming from the most difficult pathologies in this sense, that transform completely the anatomy, support the idea that the best training is on a normal anatomy. Sounds like a paradox. We need to do training on pathologies, not on normal anatomy, because the craniotomy is just the first step. But a resident does craniotomies the entire residency. But then the critical depends on real tumor finding the anatomy around in some way. So this is the point. So we need cadavers, but we would like to have cadavers with pathology, but this is not possible at the moment. So this is the point. Pathology is the key, in my opinion.
Sorry, my ignorance if this is already out, but do you have XLIF, ALIF, and OLIF models too, or are they being in preparation?
Yeah. We are going to really to unveil also this topic very soon on anterior lateral approaches on spine. So again, this is behind this topic. There is the neurosurgeon to do the general surgery step for this kind of activities. So training again is another key, because if you have the opportunity to experience and manage complication, say the general surgery step of this procedure as a new, enlarge the possibility for us to practice this also in autonomy without a general surgeon by our side.
So in my opinion, I think there is a lot of room for new things, in partly for scoliosis surgery, for large deformity corrections, and
yes, this is the next topic also for us. I mean, we are focusing now on spine and deformities, and I mean, we need to predict whatever is not normal. So again, cadaver has a limit. You don't find a nice scoliosis to correct. Sometimes you find the perfect spine. And again, we train people on a normal anatomy. So I am a scalp-based tumor. I did my first tumor on a patient. Patient didn't know. So this is the critical issue of any one of us. So we need to do our first case, not on a real person. That would be the best for any one of us.
I couldn't agree more. Thank you, Federico.
Thanks to you.
Questions from or from the participants? It seems none. If any questions occur, I will just get back to you. Okay, thank you. So Manuel, with us?
Yeah, yes.
Hi, Manuel. So thank you very much for your great presentation. It just happens to be that several weeks ago, I published with my group of students and neurosurgeons from my home country, Bosnia, one paper on 3D printing for cranioplasties, because in low and middle income countries, it's a big challenge to obtain a good cranioplasty model, which costs somewhere between 20 and 40,000 euros. And I'm very happy that I've heard in your talk a lot of things which actually are in accordance with our experience. Could you tell us the cost, actually the cost of this 3D printing, but in a number, so that we can understand just the dimension of it.
For example, I will show you this is the resin. I'm gonna show the mark, the brand. I don't have any of interest. This is the one I use. You can use with any photopolymer 3D print. This call it any cubic. It costs in the market something like, let's say, 25 euros. And it's 1 liter. And in 1 liter, you can produce 5 or 6 spinal and lumbar model. So it means you already, for this price, you already have minimum, I'm saying minimum, 5 or 6 bone model. For the silicone part, it's gonna depend on the kind of silicone you want, because you can find 1 liter of silicone by 20 euros or 50 euros. It's gonna be on you. But with this 1 liter, you can produce a lot. I'm not afraid to say like a price. Maybe it's gonna be too high or too low. But I think with 100 euros, you can produce easily 5, 6, or 7 models, a spinal model. I think with 100 euros, easily you can make it. because as you saw, the key idea, we don't make the total of the spine, not yet, but the idea is people can start to make themselves this kind of model, because we don't have any kind of no conflict of interest or any money. No, the point is show, not give you the fish, is teaching you how you can fish. So yeah, I can say 100 euros, it can be enough for easily 6 or 7, maybe more, spine models.
That's amazing. And you said you have a 3D printer on your balcony. Just
Yeah.
out of
My
interest.
wife wants to kill me time to time because, for example, I can show, this is the one I use. It's very easy. This one is the one I use. This is, This is the 3D printing I use, and you can see it's very easy. The price of this 3D printing is low cost. It can be like $400. So
where did you get this 3D printer? Where did you get it?
This one, you can get it. I got in AliExpress, I remember. Was like $460. It wasn't more than 500, absolutely not. But maybe you can get it even more cheap. Of course, this 3D printing is like the cars. You can buy a Ferrari, you can buy a Porsche, you can buy a Toyota. It's gonna be on you. But in my experience, with this one of $400, yeah, you can do all. I make skull models, I make brain models. So yeah, it's more than enough. I think it's more than enough.
Enrico has a question for you, please.
Yeah.
First of all, I had a comment to Manuel. Manuel, I thank you so much, because you remind how Upsurgeon started. In 2014, I had this small printer in house, and I had my girlfriend hating me because when we were, it was the television and there was the 3D printer. So during the night, watching a movie, and we saw this all the time,
Yeah.
So it was very romantic, let's say. So thank you, because this is actually the mindset that I absolutely like. I wanted to ask you, you probably, I say this because I had this kind of perception when this happened to me a few years ago. You should look like as an alien to your colleagues, probably, because you do something very atypical. How do they react to this? I mean, how do they support you? I mean, what happens around you?
Well, I started making model of third ventriculostomy. My first model, I used silicone of bathroom silicone, and was very strong smell, but was very hard. Right now, I'm not receiving any funding to these projects like from an institution. No, it's unfortunately I'm doing this myself in this balcony, and it's work. In the beginning, of course, some people collaborate, but spontaneously to buy silicone, because the silicone was the most expensive part. For example, Professor Jose Soriano from Mexico, he started to support this kind of 3D, because that was during the COVID time. He saw it have a future. So now we are trying to show more to people how they can do themselves, because our goal, and especially my goal, is to show how people can do it. I receive right now, I can say it's a positive feedback from my colleagues, because in the beginning was like, you're crazy, why we do this? It's not necessary. Yeah, of course, you have experience. You know how hard it is. I'll go through these canons already with the cadavers and so on.
Manuel, what is your background? Sorry, I missed this in your introduction.
I am PGI 6 of neurosurgery through the university. I also have master degrees in medical clinical administration, and a master degrees in clinical research. And I am part of the UNESCO Anatomy Committee.
Amazing. I really appreciate what you do. Keep rocking. Even if you are alone, keep doing it. Even if no one understands, keep doing it.
Grazie mille.
Prego.
So Manuel, tell me, do you use only preoperative CTs for planning, or can you also plan with MRI using DICOM?
No, well, for example, something I thought was I use myself as a volunteer from the face model I create. I create one is from skull. It's I call it bleeding skin. The idea is when you cut this face model, it's gonna bleed. So the point was use myself as a volunteer because we don't want to have in future any kind of legal issue. Somebody say, "Oh, you use my spine model." So no, I use a CT scan for the bones, and from the brain, from the soft tissue, I use MRI.
Do you see any options of you as a, let's say, lonely guy without any industry back working one day with the industry, especially with industry who produces screws, who produces cages? Because you saw some, you presented some patient-specific made cages, screws, and stuff like that. Don't you think that will have a lot of opposition and controversy against the industry who actually lives out of that and earns millions?
Well, I didn't even think on that yet because 3D printing can open a full Pandora box, a full of opportunities because some companies, yes, they produce, they test, they make all research in this kind of implant. But what if we can produce, because right now you can even print your own pig cage. You can do it. So if you have the parameters and you taste it before, you can produce it yourself. Neurosurgical department can produce themselves. Of course, have a background of a company is going to be better, absolutely, because the funding is very important in any kind of research, and this is not the exception.
Thank you. That's very impressive. Amazing.
Thank you.
So, are there any other questions from anyone?
Mirza, I have a comment. Yeah,
Please.
it's three presentation today it's great. Yeah, it's great, and I like it very much. And it's give us another perception about how we have to be very careful about the training. And I like the presentation. I like a lot about the comparison between the model, the cadaver, and the train in patient directly. I want to ask all friends here opinion if we just think the ethical issue and the legal issue in patient to be done by residents. So what do you think? When is the best time for the resident to handle the patient directly? Let's say the resident is 5.5 year training. Do you have any opinion, Frederico, Mirza, Dr. Muhammad, or Manuel, maybe? What do you think? Nikolai, are you here?
Yes,
because I was thinking, because it's very good
question.
That we have.
It's
we have three.
I like the way it was raised that we should not be training. We should not be doing the first case on a patient, and definitely, I see here a lot of enthusiastic people trying to make this happen. So we don't do that. So yeah, that's a good question, definitely, and I'll appreciate comments from the presenters.
I have my opinion about that, and I can say something. As a neurosurgeons in process in training, I can say I can compare it with the gym. I always say you cannot train with ego in the gym because you hurt yourself. You cannot try to operate with ego when you are learning because you want to hurt somebody else. So nobody knows what is the the line, in my opinion, the line when it's proper to say, you're ready to make this or train this technique in a patient. Of course not, because ethically it's not good. But of course, sometimes you as a young neurosurgeon, you're gonna say, okay, and when I'm gonna do it? When is the time? Because okay, how are you gonna learn how to make subdural hematoma if it's not unfortunately in the patient? That's the problem. That's the problem. When you're gonna try to to clip an aneurysma, you don't gonna find aneurysma in a cadaver. So it's a very tricky topic, I can say, because of course everybody wants to learn, but if you're in the other side, you don't want somebody to learn in your family, for example. So it's very hard.
Mohammed said the last thing that he said is triggered me. When my first child was born, I was in the operating room as an observer. Let's say they said to me, "Doctor, enter," and I was terrified. I didn't want to see this, but so they said, "No, enter." So I was there, and I was terrified for two reasons. The first, obviously, this was my child, my little boy, and the second was that on the table there was a first-year resident operating on my wife. So you understand the power of this problem when you are on the other side. So in my opinion, the revolution will happen because patients will ask for this. Because I mean, we are okay with this. We do any generation before us did in this way, and we are okay doing the same. But this is going to change. It's like saying, would you take a flight knowing that the pilot is a first-year pilot or something like that? You wouldn't. So it's a cultural issue. It's a cultural matter. To answer to your question, we are trying to, if you say, okay, the education on cadaver is randomic, the education on patient is randomic, you need to be lucky to be there the right day to do. If you do a nice simulation and you use it randomly in the same way, is useless. Okay, so the point is not the point how you build a curriculum using the simulation. So in program we are trying to create like specific curriculums for high risk procedures. So let's say skin incision is low risk, but if I need to more is another level. So for the higher risk tasks, we need a program where at least I need to have a couple, 2, 3 times that I already did it. And the other thing I want to express with all of you colleagues that, for example, when I did my first cases and I did my first errors, and I knew that was my first time, I was so scared. I was so, let's say, I was burnout. I was in a burnout, and I said, I want to stop this career. I want to stop doing neurosurgery because I was so stressed by this. And the reason was that I did an error simply because I didn't have a previous experience before that. So this is terrible, and probably any one of you experienced this, not sleeping at night because we did a bullshit in the operating room. We need to avoid this. And there is the technology to do this. Any one of us need to have a pre-experience in some way, at least for the risky things. Then if you say skin incision, okay, residents do this every day, we don't need a simulation for that, you know? So this is my answer.
I can only agree what you said. I think what we are lacking is generally a structured surgical curriculum. You know, a neurosurgery resident nowadays, that's the way it is in Germany, but I think in Europe and probably in the States too, there are just too many non-surgical things which are occupying a resident day and night. And he does not, or she does not have a time really to concentrate on the manual skills. And these manual skills are taken somewhere, you know, like that's the last thing we are doing in our work. The first thing is paperwork, patient admission, patient discharge, talking to the family, conferences, blah, blah, blah. And the core of our work is actually surgical part, the manual part. And we don't have anywhere structured curriculums for obtaining surgical skills. And that's why I was talking about the revolution in upsurgeon and in other simulation models. I think that should really be a part of a structured curriculum. And maybe that's an idea for the WFNS as an organization which covers the whole world, that we try to make one structured surgical curriculum for people to obtain certain skills, and to define what does somebody who is a PGY 2, 4, or 6 should know and should be able to do.
Yeah.
Yeah, I couldn't agree more with both your comments, and I think that that's the real challenge. You know, in the United States, we now, and even Europe is even worse. You know, we have this limited hours, and so the chances for the residents to come and see the complications, you know, we learn from seeing complications. We see different scenarios in the operating room, and that unfortunately, that experience is really being diluted from, you know, these work hour restrictions and so on. And so I think that making a curriculum for these procedures, whether they be cranial or spinal, is really important and something that we should definitely look into.
Okay. So Nikolai, Salman, are you there? Do you have any final thoughts, any comments?
Yeah, I'm here. I can't agree more with everything that was said. For sure, we, as initially Federico said, we don't have standardization of what we do for our motor skills and how good our motor skills at the end of our training. And I totally agree with you that. I have some observation of the way the training is in UK, and although the training is in UK is 8 years, for example, the first 2 years are mainly paperwork and different other stuff, and they don't. The trainees rarely touch any surgical instruments. So I think that what you all said is very important. We have to have a curriculum. At the end of the day, we are surgeons, and we are trying to educate surgeons, not clerks and officers. And we have to develop motor skills. If we can find a way to standardize these motor skills, that'll be great. And if we can try to measure these motor skills at the exit of the training, that will be even better. And I think the only way to do that is to do that via simulations, because the cadavers, most of them are normal, and we cannot do that on cadavers. So I think indeed the only way to do this is via simulations. And I admire all these guys which are developing simulators, and they're getting bigger and bigger and better and better. And I think there is a light at the end of the tunnel.
We hope.
We hope. Always.
It will.
Thank you, Mirza and Nikolai and all the organizers. I want to congratulate with the incredible audience, a lot of people. So from you. So I appreciated the quality of this.
Great. So I think we had a very good discussion, and we had very good presenters, and we had very good questions, and we had very good experience of all that has been said today, and good conclusions. So I think we can conclude with that. I thank everybody for your time on Saturday, and I hope that you will continue with developing what you're developing. It's been great, and I'm very happy that there are people which are moving all us to that direction. So thank you again for the participation, and I will hope to see you soon. Maybe most of you will be in Cape Town.